I'm Peter Georgilopoulos, sports physiotherapist based on the Gold Coast in Carrara. Today we're just going to talk very briefly about anterior knee pain, which is easily the most common type of knee problem presenting with most of my patients and most athletes. Unlike most of the structural issues inside the knee joint, which involve cartilage, cruciate ligament, or any other bony structure within the knee joint, anterior knee pain is specifically located at the back of the kneecap. If we can just have a quick look at the anatomy of what's happening behind the kneecap, you'll see that there's a very distinct ridge, and that ridge sits quite comfortably within that groove that's formed in the front of the femoral condyles there, between the femoral condyles. Those two bones articulate and the kneecap actually floats in that position and is held there by the patellar tendon and all the other soft tissue structures and muscular structures around here. And so it can sit centrally located so that when we're bending the knee and straightening the knee, that ridge can sit quite smoothly within that groove at the front of the knee joint. Any disruption to the posterior surface of the kneecap or the front of the knee joint here can cause some grating. We call that crepitus, and that can be painful in itself and can lead to a great degree of erosion and osteoarthritic change at this point here, which can of course give us constant pain in a severe form. The characteristics of anterior knee pain are generally pain on prolonged sitting. We call that moviegoer's knee, where you feel like you need to straighten the knee and stand up and move it to relieve some of the pressure. And the reason for that is, of course, that there is an inflammatory response occurring back here, and if we're immobile for any period of time, that inflammatory fluid's really got nowhere to go, so it builds and builds to a point where you start to feel as if you need to relieve it by gently moving the knee, and in doing so, the action of moving the knee can relieve some of the pressure that's been building up from inflammatory fluid. The causes of anterior knee pain are manyfold, and it's largely to do with poor biomechanics. One of the most common features of poor biomechanics is poor foot posture, where we've got flat arches. So if I pop this down for a moment and just pick up a model of a foot. This is the inside aspect of the foot here, and of course most of us know that that's where the arch sits. Having a reasonable arch is extremely important in good foot biomechanics, and of course weight bearing through the actual body as well too. Being able to disperse impact forces through the body. The reason for that is that as the foot lands normally on the outer aspect of the heel, and movement occurs through the mid-stance phase, where the weight's going directly down through the shin, that foot will splay and shock is absorbed, and then we progress onto the toe-off phase, where we just roll the foot marginally across onto the big toe, and the big toe is activated and pushes down onto the ground and allows us to propel ourselves forward. So it's a very clever mechanism of forced dispersion. Not only do we get a rocking from back to forward, but we also get a rocking from lateral to medial, from outside to inside. And the ability for the foot to splay in the mid-stance position, and part of that of course is the ability of having a reasonable arch there, which allows the foot to splay out, allows us to absorb the sort of impact forces that occur when we're running and jumping and doing a lot of other weight-bearing activities. What has this got to do with anterior knee pain, you may ask? And the answer to that is, of course, that when we're looking at the knee, the ability to weight bear and absorb shock at the foot site will have a significant influence on what sort of forces are being moved upwards into the knee and ultimately into the hip and lastly into the lower back. The increased amount of weight bearing behind the kneecap increases the forces behind the kneecap. So immediately we can understand that if there's any predisposition to getting some degenerative changes, having poor foot posture and running on hard surfaces is going to impact the back of the kneecap increasingly over many years, and we can end up with quite severe degenerative changes at this point here. Two other factors, and they're interrelated. One is quadriceps tightness and hamstrings tightness. And both those aspects, of course, are very, very important to what happens behind the kneecap. If the hamstrings, as the hamstrings attach back at this point here below the knee joint, if we've got and contract. So if we have tightness in the hamstrings, what tends to happen is that as we're trying to straighten the knee out with increasing hamstring tightness pulling back here, the forces that are transmitted to the front of the kneecap increase. Similarly, if we have tight quadriceps, which are pulling very, very hard, the compression forces behind the kneecap are also increased. So any underlying degenerative changes is exacerbated or are exacerbated. The last thing we need to look at is what happens when we have any sort of knee malalignment. And we call this a valgus deformity, or a knock-knee deformity in common lay terms, or a verum deformity, and that's a bow-legged type deformity. Both these types of deformities do alter our biomechanics and stop us from being able to transmit weight straight through the middle of the femur or the thigh bone, down through the middle of the tibia and through the second ray in the foot. Any deviation inwards or outwards will obviously alter those mechanics, and ultimately we can't really track very well through the groove when we're working at a slight angulation. So it's quite important that any deviations are attended to in some way or form. These are skeletal deviations, of course, and so we can't really make any adjustments other than artificially through the use of orthotics. And this is what an orthotic looks like. This is a sports orthotic, so it's a very soft device. Of course, there are many different types of orthotics. This one here has got two dual density foam. One is a softer version here at the front where you're getting a lot of shock absorption at this point here, and the posterior part of it in green is a much denser type of material, so it stops any rocking and rolling, or tries to limit that within the shoe. It's highly important that the type of shoe we select also matches our foot type. So anybody with a flat foot would be best served by having a shoe with an inner stability aspect to the medial compartment of the shoe. The characteristics of a stability shoe are that you need to have a very firm heel counter at the back so that it holds the heel in firmly and the foot is wedged within the shoe. We need to have a medial amount of reinforcement here at this point here, so that when we're coming across from the outside heel to the inside part of the foot, that part there is reinforced and the foot doesn't collapse earlier than what we would like it to be. If we can keep that foot up somewhat, then we have a much greater chance of dispersing the forces through the foot when we're impacting through running. The last thing, of course, is to add this orthotic inside the shoe. Normally what we would do here is just take the inner lining of the shoe out. We can't have the shoe build up too high. Otherwise, you'll find that your heel will be raised above the heel area, and so we replace the inner lining of the shoe with the orthotic, and so we get the two aspects of benefit there. One is the medial support on this side and the inner control that's offered by the shoe. And from a technical point of view, from a therapeutic point of view, what we can offer here is, of course, reducing hamstring tightness is vitally important. Calf tightness is vitally important. The shoe, as we said, is extremely important, the types of surfaces we're running on, and trying to avoid low squatting positions or running up hills repeatedly.